Okay, well, I would like to take this opportunity now to say thank you for all your generosity. And Chemo Jim, will you do the honors of introducing our guest?
Yes, thank you, President Lorraine. The one thing I want to mention before I introduce Dr. Jim Gude is that in the current Rotary magazine, there's a full article about our global telemedicine project, including a mention of our Dr. Prakash in Nepal, who's doing our teleconsult on our global grant project. And then also, if you thumb down, that's on page 7. If you go down to page 14, and there's a full article, including a photo of our guest speaker, Dr. Jim Gude. And so that's right now in the December Rotary magazine. And I can also email a copy to you. I should do that, Lorraine, just so your club members have that. Also on the call, and she just jumped off, is Farheen Abbasi, our Director of Communication and Social Media for our global OffSite care, our global telemedicine nonprofit. And unfortunately, she stepped off. She's a medical student, and we get so many things done we couldn't accomplish without her. But and she just jumped off. I wanted her to say a few words. Anyway, our guest speaker today, you heard me a few months ago speak about our global telemedicine projects, is Dr. Jim Gude. He is our director of all of our health projects, a medical doctor. He's an intensivist, and he specializes in ICUs and working in ERs. And he had a vision about 12, 13 years ago about just expanding medical practices using technology. And so he collaborated with the Rotary Club of Sebastopol, and they started doing projects together, which developed into global grants and so forth. Dr. Jim Gude is professor of medicine at University of California, San Francisco, and some affiliates, Stanford, Pacific University, and so forth. And is just a great guy. When I introduce him, I always say that he's got 5 full-time jobs. I don't know how he does it. And in the pandemic, he's he's out working with the COVID cases on a daily basis. This amazing doctor saves lives on a daily basis, like we drink coffee. It's a typical daily task. He's an amazing individual, and I don't want to bore you any longer, but it's my pleasure to introduce my very good friend, Dr. Jim Gude. Jim?
Jim, thank you. Can you hear me all right?
Yep.
When's the last time you saw a bow tie? I've got a bow tie on. You don't see those very often. And when's the last time I could sing happy birthday on Zoom? This has been a big day for me, singing happy birthday with a bow tie. Why do I wear a bow tie? Well, one of my professors had one, and I know I could never be as smart as he could, but I could wear a bow tie. That was number one. And the second is that when you see people in telemedicine, you have to look decent. You have to have a white coat on, and you have to have a tie on. It's sort of the uniform, if you will. A bellboy has uniform, a trolley driver and so on, and a doctor does too. So I see quite a few people in telemedicine, and I need an apparel. So I've got a white coat on, and it's a little cool in California. I've got a sweater on and a bow tie. Do you have any bow ties? Do you wear bow ties, any of you? No? Tim, do you wear bow ties? No? No? All right. Anyway, so one of the good fortune I've had was to run across Rotary. This was about 2000, so we're going to say 12, 13. Mike Cook, who's was the international head of the committee, and then he was the Rotary president of Sunrise Sebastopol, came to some lectures I was giving in the hospital. And he said, telemedicine would fit a Rotary goal in terms of getting better health care out in the world, sort of like, polio vaccinations, or maybe COVID 19 type of vaccinations. And I had the good fortune to join up with that local Rotary club, Sebastopol and Sunrise. And then we got Rotary grants and other Rotary clubs and chemo and others came on board. And it's enabled me to practice medicine on a global scale using telemedicine. It's been a pleasure. You know, before that, I was a local phenomenon, you know, Northern California. I enjoyed it. It was very nice and so on. But this is a chance in my, and I'm 81, by the way, okay? It gives me a chance to do something globally, meaningfully, in a way that I can do it at home. I'm in my home right now. I'm in my library, you know? And I'm also on call in several hospitals right now, and I do consults and intensive care units and so on. I have my own company, which we run about 15 hospitals doing telemedicine. This is the humanitarian global extension of what I do locally, if you will. It's been a pleasure, you know, that I've done it. I'll show you a slide deck here and give you some of the goals we have. There are really three goals. One is education. Two is going to be consultation, getting consults out where they're not in the world. And three is trying to get electronic medical record out to little hospitals. So let's talk about a little bit what we're trying to do. And this is all made possible by Rotary. Thank you, thank you. Now, we give CME a credit to Global Grand Rounds. I just gave a Grand Rounds. I gave a Grand Rounds on the treatment of congestive heart failure. And we had a case presentation. And after my presentation, I had a student at Western University give a student presentation of congestive heart failure. And then we answered questions. We were going to see a patient I saw this weekend in a place called Watsonville, California, in the ICU, but he was discharged last night. We usually go and see a patient on rounds, and I talk to that patient and examine that patient using the technique of telemedicine. So it's part and parcel of what we do on the rounds. But we've been doing these global offsite care rounds, telemedicine grand rounds, really since about 2013. And they're a pleasure. And what's nice about it is with the help of Farine, who Jim mentioned, we're getting more international type participation. And I have presenters from Nigeria, from the Congo, from Haiti, from the Philippines, from China, from India, from Nepal, who will give a grand rounds and bring forth the fact that this is an international association of doctors and students and others, health professionals trying to improve. Now, our emphasis in last year has been COVID-19. For example, I talked about particularly COVID-19 with congestive heart failure, gave an example of a patient who had an MI and bypassed, had COVID-19 heart failure, and how we treated the patient to get better. And it's a major comorbidity in terms of getting COVID-19 and a problem. About 20% of the people get heart failure when they have COVID-19. So that's really been a big emphasis we've had. These are some of the rounds we've given. I've tried to emphasize COVID-19 in the last year. For example, early outpatient therapy, that's a very neglected area. If someone has COVID-19, you don't just sit on your hands. You do some things like zinc lozenges and maybe curcumin and when we start storage at home are antivirals and role of antibiotics. It's all in that lecture, but it's not talked about very much. But what do you do if you have a COVID-19 and you're not in the hospital? You should do something if you have any symptoms. We talked about neurologic complications. They're very, very common. We're seeing people now who are elderly who present in the emergency room with only delirium. That's all they have. They don't have a pneumonia. They don't have gastrointestinal problems. They don't have neurologic problems otherwise, but they are delirious. And we now realize that this virus, the COVID acute type 2 virus, actually sets up an infection in the nasopharynx. They can go transmigrate right in the brain and get a cerebritis, get a viral infection. And we're seeing older folks with that as their main complication. Diabetic ketoacidosis, this viremia can affect the pancreas and cut down your ability to make insulin and lead to diabetic ketoacidosis. We talk about the treatment. Each of these rounds, we have a case presentation and actually talk about how we treat that patient. open to questions. And I always I have a medical school involved with this. I have a medical student give a presentation when there's not a vacation or some other reason. So education is really the biggest thing we do. And we're switching off of me, Dr. Gude, onto others. These would be professors that are, and teachers and medical students that are different entities. And with the help of Farine that Jim, that Kimo mentioned, we're trying to really broaden our scope. So we have a presentation of, for example, tetanus from Nigeria, presentation, believe it or not, of polio from Nigeria, a presentation of Rift Valley fever from Uganda, and so forth. Diseases we don't see much of, or like malaria. I don't know of any local specialist in malaria, but in the world, that's one of the biggest diseases in terms of infections. So education, it's a very big push we have, and it's going well. Thanks to Rotary, we can give free CME credit to anybody who attends and fills out a form and sends it to us. Now, in the real world, to get CME credit from a university, it's $100 a credit. So people can join us every week and meet all of their needs for re-credentialing, for licensure, for board exams, etc. And this all also fits many foreign countries, Nigeria, for example, and Uganda. Our credits are good. So thanks to Rotary, we can give free education that's accredited. And we try to keep the quality very high so that it's worthwhile. So education is number one. Next slide, please. These are lists of some of the grand rounds we had. Making the telemedicine encounter meaningful. For example, how you use telemedicine, how you look at the patient's face, and how do you examine the extremities, and how to use a stethoscope, and how do you use ultrasound? By using ultrasound is better than the doctor palpating your abdomen. We can really use ultrasound to see what the liver is, and if there are gallstones, and look at the pancreas, and look at the spleen, and so forth. So we talk about making that encounter meaningful. And the telemedicine encounter can be in the hospital. We've limited ourselves to hospitals. It can be in a clinic. It can be in the home. It can be anywhere. Telemedicine has really, in the last year, jumped a decade in terms of the 10 years before. It's a rapidly evolving field. Hiccups, we had a grand rounds on COVID-19 give you hiccups. Hiccups are a big problem when you can't breathe because you desaturate because you're not breathing. And we have emergencies with people who get pneumonia with COVID-19 who get the hiccups. We've got to stop the hiccups, or they're going to be being intubated because of hypoxemic respiratory failure. Long haul syndrome, I think that has to do with having had COVID-19 and getting a cardiac involvement, like a myositis, cardiac myositis, and afterward, for the next year, having fatigue when you do anything, plus breathlessness. It's really a cardiac limitation. Very slow to get over. That's the long haul syndrome. Neurologic complications, DKA, obesity. What do we do about obesity? What if they have influenza at the same time? These are all lectures, if you will. Next slide. So we donate to the hospital a kit for them to do consultations, good consultations. It's a little kit that has, first has a big screen and a microphone so they can join us on our grand rounds. Okay, so we give them a computer, a big screen, and a microphone. They've got that. Then we give them a little device called a Kubi that'll turn in all different directions. You can put an iPad or an Android pad in it, and it becomes a robot, a very inexpensive robot. And we found that we gave these units, and the hospitals aren't using them as they should because we didn't coach them. So we're going back now per hospital and getting a clinician or clinicians who use this equipment and coaching them how to use the equipment. For example, let's say they have a bizarre neurologic case. They can get the case, have our equipment there, have the patient on the screen, have a doctor come and join and look at the patient. The doctor can talk to the patient, look at the vital signs in the screen, look at the chart, etc., and do a consultation. So we're setting the hospital up so with the equipment we give them, they can have a consultant come from anywhere in their country or the world, if you will. And we've set up a special hotline for COVID-19, in all of our sites is 24/7 manned by a group of very experienced intensivists who happen to work for my company, and they've donated their time to do this. When they're on call in other places, they take call for this. We're developing a smartphone app. And this app is that you call a number and then you say, what's the best antiviral? And the number says, it's called Dr. Mentor Consults. The app says remdesivir. And then you get sent to your phone by message a detailed example of why that is the best antiviral with the one best article supporting that. So this is an app developing that we're doing that will, anybody can dial this number and in the world get a answer. We find we have to change the answer in different parts of the world. The answer in Kenya is very different than it is in Australia. But that's really an interesting project. I'm doing that with medical students on that project. In terms of one other thing, we'll take international medical students, like for example, from the Kabbalah University in Uganda, or from the Jos Northern University in Nigeria, or from a medical school in Northern India. We'll pair them up with an American medical student to work on this project, the smartphone app, Dr. Mentor Consults. So we're really teaching medical students, giving them almost a thesis project to work on. And that's part of our consultation type training. So education number 1, consultation number 2. Next slide, please. And we're advocating for electronic medical record adoption. To really practice medicine well in the world, you need to have a hospital system. It's not just an electronic medical record. It's a system that can bring together the pharmacy and x-ray and outpatient and records. It's really a hospital management system. And the EMRs now are really hospital management systems. You can run a hospital with it. And these small hospitals, and I've visited many of them, they have no medical records. They have no past history on patients. They can't process lab tests. They have nothing to look at regarding history on the patient. We're advocating supporting a hospital that wants an electronic medical record with microfinancing, that we will give them a 3 to 5 year loan, and they can find in their country an electronic medical record that meets their needs, and then pursue that. Now, our thesis is that you make these little hospitals efficient, and they will be economically successful. There's a lot to microfinancing. All began in India, supporting women getting started in small projects in Africa and so on. We're trying it in terms of little rural hospitals, trying to get a hospital system that will be cheap, affordable, is local, and will enable them to really enter the 21st century. And they can pick the medical record they want. We're involved in developing one it's called Harmony MD, but that's because I think we need a very cheap one. It's based in Sebastopol. I've been involved in it, and it's competitive, but it's just whatever they pick in their country, if you will. So education, consultation, and trying to enter the world of electronic medical record for them to do this by their choice with their financing in terms of their country. Next slide. And I really enjoyed traveling around the world, whether I visited Africa and China and India and Nepal. I've gone to many of the Rotary International meetings at Portugal, and Australia, elsewhere, and I've really enjoyed it. It's been to me the way as a physician to get and do global practice. And Rotary is such a good global group. You're like the UN. You've got about 30,000+ clubs, I think about 2 million members, and you're honest. Before I hooked up with Rotary, I did some work with the Methodist Church and Catholic Church. We had great troubles in terms of religion going to countries. I remember I went to Liberia and the Congo and so on with a Protestant group, and that was a problem in terms of the Muslim population where it was and so on. And also there's a great problem in terms of trying to give monies or equipment. Rotary is much better than doing it to anybody else because you're business people, you know how to handle these things, and honesty is part of the platform that you work from. So it's been a pleasure working with Rotary clubs in different parts of the world because of their honesty and their desire to serve and their ability to handle business type arrangements, if you will. So this is Mike Cook on the right. He's the president of Global OffSite Care. Dr. Sablock, our representative in Northern India, colleague of Dr. Sablock next to me, and I've got the hat on, the Indian hat on, and with the bow tie, of course, I've got on there. But it's been a great pleasure dealing with chemo and the other Rotarians because they've opened the door for me as physician to do what I love to do, which is teach and hopefully improve world health. I'm open to any questions.
Dr. Gude,
Yes.
This is Alan Okinaka. I have a quick question.
Sure.
Lately I've noticed that there's a stronger linkage between behavioral health and medical health. How is behavioral health working as far as telemedicine goes?
Very, very well. You know, for example, the interface, like you and me looking and so on, I can talk to you, I can see your emotions, so on. We have psychologists and psychiatrists, and also we're now getting into ethical type consultants regarding end of life in the ICU, coming in and giving their expertise and comfort care, when really the objective is patient comfort and having an expert in that to handle. So from psychology and psychiatry to ethics, telemedicine is very applicable. For this reason, we can bring a consultant in where they don't exist. For example, I got a call recently from a little hospital in California, 25-bed hospital. They have no behavioral sciences. They said they had a terrific problem in terms of setting up end-of-life care. So we had a consultant who does that for us. He's the end-of-life care consultant. Go there and talk to them about how you relieve pain, how you relieve nausea, how you relieve agitation in terms of the mechanics of end-of-life care, if you will. So the behavioral sciences are very much a part of what is needed in terms of reaching out. We are emotions and physiology, et cetera, and the emotions have to be dealt with. I think it's very applicable. I really do. In fact, psychiatry is one of the most successful telemedicine fields. Number one, it's not readily available, but number two, you can dial up with a group, have a competent psychiatrist and evaluate you and so on, and get an opinion in terms of use of psychotropic drugs, which is very specific. You have to have a lot of experience to handle those drugs. And the diagnosis, what's the diagnosis and what is the approach? Is it behavioral? Is it really pharmacy? How do you do it? So I think telemedicine has really had real applicability in terms of behavioral sciences. Very important.
Thank you.
I know we just have a few minutes left, President Lorraine. If I could just mention one thing. When we do our global telemedicine projects, we bring in a group of doctors, and I've been with you at the EICU, Dr. Gude. And when these doctors from China and from Nepal and from Uganda, when they come in and they see the EICU, it's magic for them. Things happen. Could you just describe, first of all, describe the EICU and then describe what happens when we bring on Rotary projects these medical doctors from these other countries in to see what you can actually do with technology?
We used to have actually hands-on. We'd have a group come here. Jim mentioned from China, from Nepal, from Uganda. We'd have a group come here, about 5 doctors, and Jim and another fellow, Steve, and myself, who would take them around and do different things. We took them to an electronic ICU we have in San Francisco, and this ICU picks up the care of patients at 4 p.m. and follows them until 7 a.m. the next day. They're seen by doctors in person during the day, but at night, we're available in terms of intensivists in approximately 150 beds. And there are 2 of us working, and we've got 2 nurses and 2 administrators, administrative persons. And we can manage about 150 patients well overnight with economy, with expertise. And if we need to have hands-on, we'll call the emergency room doctor to come up and put a chest tube in or a special line, something. But it's an idea of running ICUs and hospitals at night with telemedicine, be it a specialist in the ICU or specialist on the ward. Number one, it's economical. And number two, it provides best care. These are people who are boarded, and we really pick them for their expertise. And it's a system of saying, listen, at night we can handle things by telemedicine, but it's best during the day to have hands-on and touch and feel and hugs and so forth. They're very, very important. And we show these doctors the role of telemedicine for night coverage particularly. And they can set up in their countries a similar type EICU, if you will. And in terms of the interaction with the doctors, it's terrific. I've learned so much in terms of friendship and how they practice medicine with a group from China, with a group from Uganda. I mean, it's really been a delightful thing. And Jim shows me all the best places to eat in San Francisco. He knows it very, very well. So I've learned a lot of new restaurants. So that's been part of the yield.
Well, thank you, Dr. Gude, for your presentation. I know that if we have questions, we can direct them to
Absolutely.
Chemo.
Yeah.
Chemo, he joins our club on a regular basis. I think he
I'm
has
here.
dual membership. So thank you very much.